Thank you, Dr. Sahu, for inviting me. So we will keep our discussion mainly to stage 1, 2, and try to touch a little bit about the stage 3 also. Thank you to the panelists for joining. So this is what is very important to understand about our lung cancer scenario. You can see the 5-year overall survival, and it's something which is very important because the survival is too good in the first stage. That's a different topic that we'll discuss about how common it is. And the survival start dropping from 1B onwards, and by stage 3 it is hardly 20%, and we know what is the outcome in the stage 4. So this is a hypothetical case. A 67-year-old male non-smoker presented with mild cough. An X-ray showed a very small lesion in the left upper lobe, and CT was done, which showed a left apical lobe lesion. So then later on the PET scan was done. You can see a PET scan lesion in the left upper lobe, and a small lesion, and you can see a surrounding lymph nodes also, but they were not so bright enough. So the PET scan finding showed that there is a very well FDG avid lesion in the left upper lobe with adjacent pleural tags and non-specific reactive nodes in the prevascular area. And important thing was that there was no distant metastasis. So I will start directly with the question to my surgeon colleague, because these are the cases which will directly go to them. Dr. Vinod is here now. So what we will do now, directly you will go 67-year-old, what kind of counseling will be going ahead, and anything else you will do prior to doing a surgery?
Yes, sir. Obviously, the patient is the age of the patient is 67 years. So first of all, we should see for the performance status of the patient, and if it fall in the 0 or 1 performance status is good, then we can go ahead with a pulmonary function test. And in this kind of the cases, we need not to go for biopsy and some invasive biopsy. We can go ahead with planning of definitive surgery. And in that case, we can manage by after doing all the preoperative requirements. If the patient is fit for surgery, then we can take the patient for surgery. First, we have to sample some lymph node from the mediastinal. If these comes out to be positive, that to be N2. So then,
so Dr. Vinod, you are telling that biopsy is not a must in these kind of cases?
Sir, if the patient is having clear-cut surgical means, if we are having the facility of frozen section examination, then
so
we
this
can avoid
patient,
biopsy.
yeah, that is what I'm telling you. This patient has got a very well-defined FTG avid lesion, which is nearly 7 to 8, and not 8, I'll say around 15 to 20. With so what I was saying is that biopsy, I feel most of us do it medico-legally also as a must procedure. Normally, we don't go directly ahead with the surgery, right?
Yes, routinely we do follow this thing, but if the patient is having clear-cut operable lesion and the patient is totally fit, then we can do what we can do. We can have a VATS, means video assisted.
Awesome.
Yeah. We can have intraoperative cytology and we can proceed with that.
So in your practice, how much help you are taking from the pulmonologist regarding EBUS, or you do only yourself mediastinal?
No, sir. We usually follow the EBUS only. We rarely do mediastinal.
Yeah. So basically, what I was telling is that prior to doing the surgery, you will be doing an EBUS.
That is also to be recommended during the definitive GA, means the patient is in OT. We may avoid multiple procedure on the patient in that case. So we can take the patient in the OT. First, we can do EBUS.
No, what is your normally your routine practice? Because these lesions are not like looking like any kind of emergency. You have ample time to decide what you want to do. There's nothing in emergency here. Here everything is elective. So what in your clinical practice, you do not tell कि मैं सब कुछ एक दिन ही OT में करूँगा. Normally you go ahead and do a EBUS, do a biopsy, then plan the surgery accordingly to it, right?
Tejinder sir, Dr. Samir here.
Yeah.
Can I interpret for a few minutes?
Yeah.
So
Please,
I want to highlight one point here. So means I want surgeon's opinion here. If you see the stations of lymph node, which can be targeted by EBUS, I think what I remember, only 3 stations cannot be targeted by EBUS.
Yes.
Which can be targeted on minestroscopy, and these 3 stations doesn't make any difference in surgical management.
Right.
So even if you miss that lymph nodes on EBUS, that is not going to change your surgical management. So that's why the practice has changed from minestroscopy to EBUS, which is much less invasive.
Even
so this is my understanding. I
yes,
think
even
this is
why. Yes. Even I feel this is the understanding. That's the reason why I said this surgery doesn't require any. You can go electively in a very slow fashion. No need to be in a hurry to do everything at the same time. So, Dr. Vinod, just wanted to ask me. I'm asking nowadays. Doing this intraoperative midoscopy and EBUS, how much you have seen the practice changing in the last 15 years? Now, I think every center has got EBUS doctors.
Basic practice is like that. What you are mentioning, the patient comes to us, then we first send the patient for EBUS and do the. But the patient is totally fit and lesion is looking like operable upfront, and the lymph nodes, they are not FDG awaited, not looking on radiologically and PET scan wise, they are looking means negative. Then we can go upfront with intent of definitive surgery, and then we can plan accordingly in the OT. If there is some doubt, then definitely we have to send the patient for EBUS and the staging of the mediastinum and lymph node, and then the staging wise we can manage the patient.
Right. But so one more question to Vinod. In your practice, how many in a 6 month? I'm just asking you. I know you are coming from a very busy place. In a 6 months, how many patients you have operated for stage 1 and stage 2 CLR?
I am not operated.
Yeah, that's very important because I'm asking 6 months. I'm not asking 1 month.
It was clear-cut operable type of patient, but rarely we find these kind of patients. Rarely.
Yeah. Samir, how common you have in a year? How many patients you are given adjuvant therapy, stage 1 and 2? The other way to ask question for you for a medical.
So in last 1 year, na? So you could have asked last 2 years, so I could have said 1 patient. So in last 1 year, not a single patient.
Right. That's very important. That is very honest answer. Huh? So
yes.
Same question to because how many in a year I will say adjuvant chemotherapy?
So to be very frank, sir, pre-COVID the number was 0. During COVID, 2 patients, and those patient was also detected like the CT scan was done for different reason.
Yeah, right. It's something very. Now question is for to our radiation oncologist Gaurav. Now everything is changing the whole way. I'm just talking about stage 1 and 2. Yeah. Do you think with so much new data coming, I think there's a trial also which has totally taken out the PORT out of the picture. You still think that there is a role of post-op radiation in a stage 1 and 2? I'm not talking about 3, honestly. 3 is a totally different disease.
So as such, there is no role in what I would say, only in case margin is positive, in only that subset it is required. Otherwise, right. As such, there is no role.
Right. I agree with, that is what I asked you the first question about how common, how often we see. Honestly, in 1 year, I had given only 1 adjuvant chemotherapy, and very uncommon to see patients, and it depends upon the centers. One of my colleagues is there in Asian Cancer Institute where Dr. Raman Deshpande is there. They do tend to get slightly more number of patients as compared to me. So I think we are quite okay with certain things. Nowadays we are doing PET scan almost for every patient. We do go ahead with the tissue sampling. We do the biopsy. My question to all of you is that in this patient who is early stage cancer, how many of you are doing MRI brain? Samir?
Sir, each and every patient we are doing.
Each and every. Vinod, I think Vinod is the main person.
If we are planning for surgery, then we have to do, sir.
Yeah, that's very important. So, because I think you are doing for everyone, MRI?
Yes, sir.
Brain?
So if patient is going for surgery or definitive CTRT, I think MRI is required.
Right. Gaurav, I think any change of thoughts, or you believe in the same thing?
Sir, less than 3 centimeter, I don't go for MRI, else I go.
Okay, less than 3 centimeter, you're talking more of a T1, basically.
Yeah.
1A. Yeah. So I think it's a very nice thing which Gaurav said. There are some centers which are not doing it for a 1A. But most of us are doing the baseline MRI prior to going ahead with the surgical. Any surgery patient, we normally do it. It's a very funny disease. So Gaurav, you feel that the biopsy is a challenge for early lung cancer? Or there was a time people used to do FNAC. Agree, nowadays almost all of us are sitting in a city. That's, I think, it becomes very easy for us. Or still you feel it's a challenge?
No, it's not a challenge in present era.
Not
it's eaten comfortably.
Okay. Vinod, can you just tell us about, you have described about mediastinal staging. Samir mentioned about the EBUS, that there are 3 stations which are not possible to go ahead and do the biopsy from with the EBUS. But honestly, end of the day, it will not make any change in the treatment, right? So you think EBUS still basically holds ground, or I think there are still challenges with the EBUS also? Vinod?
Yes, sir. There are challenges because most of the person in EBUS, they are doing only FNAC. They are not taking definitive tissues. In early stage cancer, non-small cell lung cancer, we need biopsy for further testing of the
No, but EBUS, they do the biopsy. The needle is quite big enough to take a biopsy. It doesn't do the FNAC.
They do, but sometimes they do some FNAC only.
Okay,
This
so
is
basically,
this is the main drawback, I think, in EBUS as compared to mediastinal. But mediastinoscopy is invasive, more invasive, and more surgically means challenging thing. And routinely, most of the people are means reluctant doing mediastinoscopy.
okay, fine. But I think, to my knowledge, almost wherever I am practicing now, in the last few years, I think everyone has gone away from the mediastinoscopy. They rely a lot on the EBUS. And there are now good number of centers which are doing it, and good number of trained people, I will say, who have started doing it. And they mention all the stations very nicely. Yeah. So they mention very nicely all the stations when they are taking the biopsy, and it is very helpful. And like I said, there is no emergency here. Everything is elective. We need not rush the things very fast over there. So these are this patient underwent EBUS. There was no enlarged mediastinal node, physically fit, underwent surgery. Now, the post-surgery, the specimen, you can see it was basically a T2 lesion and invasive adenocarcinoma, and there were around 2 nodes, station 10 and 11, they came positive with metastatic deposits. Now, what are the next steps? My question to all my medical oncologists and Gaurav also is that, do you do any molecular marker in this kind of patient, and if which type of molecular marker, whether you go for a extended panel or you just do a limited panel? Vikas and myself are both sitting in the home. I think only person who is working still is Vinod, very busy man. And I think Nikhil is also there, and Gaurav is also in the home.
Samir ko bhul gaye tum.
Sahu, I think, is also in the clinic.
Sahu is at home
Samir
relaxing.
is also. So very important, because in the elective case, you have ample time to decide which marker you want to do it. Because
yes, sir. So like, as far as the treatment part is concerned, we know that the only approved, we have approval only for osimertinib, that is like patient has to be positive for EGFR. But
you will not send anything else?
Yes, sir.
Only EGFR?
So that's what I am telling, sir. I will send the whole NGS that might my patient benefit, like if some trials are ongoing, adjuvant trials are ongoing.
अरे adjuvant trial में सिर्फ ALK और EGFR का चल रहा है और कुछ नहीं चल रहा.
That's what, sir. If positive for ALK, I can send for trials.
Okay. So Gaurav, what do you do?
Usually EGFR.
Samir is there.
Sir, PD-L1, CPS score and EGFR, these are the only have therapeutic implication. Otherwise, you can do NGS, but it will not change if there is any other mutation. It may help in future management. So it is not wrong in doing that, but immediately it will not help us. Only EGFR and PDL1 will help.
So that's a big problem happens. One of my patients, basically somebody had done an extended panel, ALK came positive, and it became like a big issue. But still, anyway, we gave adjuvant chemotherapy, and after discussing with the family, we had no other choice but to give crizotinib to the patient also. She's doing very well. I think Nikhil and myself both have treated that patient. So it becomes very difficult. I know that Alchemist is still doing it, but right now the guideline talks only about two things, PDL1 and the EGFR. Dr. Vinod, I think this is, I know the surgeon's area is a little bit away from here, but we normally send all those things. So because you feel that in the future, extended NGS might help?
Yes, sir. So like we have precision oncology drugs, and like in metastatic setting, they are slowly infiltrating in adjuvant setting, sir. And they are wonderful drugs, very active, efficacious drugs. So I don't find any reason why they will not be benefiting our patient in adjuvant setting. So it's just a matter of time, sir.
Yeah. One small question to you is that, you think I am talking about medically fit patient. If you have 10 patients who are early lung cancer, stage 1 and 3, how many of your patients ultimately undergo surgery? Vinod, you are the only surgeon. I cannot ask Vikas to take the patient for surgery. And you have to unmute yourself. You have to unmute yourself. Because Vinod, you have to unmute yourself.
Vinod, yeah.
Yeah. So how many percentage of a patient undergo resection ultimately?
Ultimately, resectable cancers, they are basically, I have encountered only the young patients, the operable patients. Those came to me, but I am not I am not practicing as a whole oncology, like so I am not getting all kind of lung cancer, so that I can separate them operable and means higher stage. I usually get patients from the medical oncologist side.
So basically medical oncologist पूरा छांट बांट के आपको ऑपरेट करने के लिए ही बोलता है. Non छांट बांट he doesn't give it. So you have a very good medical oncologist who sends you patient. Anyway, that's a very good thing. Okay, Gaurav, I think this is a question for you. I think you have answered about the post-op radiation early stage. Any role right now in the present era except for the margin positive, right?
Sir, no other role. In case any other high risk factor is there, it's better to go for adjuvant chemo.
Okay. Some patient, they do not want surgery.
Yeah.
How much is the role of SBRT and proton? I'm talking about proton.
Sir, for sure, a patient not willing for surgery or medically not fit for surgery, in that particular case, early stage should go for radiotherapy, especially SBRT.
Okay. What about the role of proton? So much now people are talking about proton now. You feel proton is better than SBRT?
Sir, proton is definitely better than SBRT, but for a small lesion, it will not make a much difference.
I have very less question to you. That's why I'm asking about proton.
Sir, not much difference. It will not create much difference, for sure.
You know, Apollo Proton has put up a nice paper on the early NSCLC in a medically unfit patient. They had some good data also on it. That's the reason I was telling you.
Okay.
So anyway, I think, yeah, the molecular panel report came as L858 mutation positive. Dr. Samir, what is your next approach?
Sir, one point I want to highlight here. So we were discussing whether we should do a broad NGS or only EGFR and PDL1. So one additional advantage of broad means NGS can be, if we think one step ahead. So we have a good data of monitoring with CTC in lung cancer after surgery. And there is a good data.
But Samir, I agree with the CTC, you know, but CTC is something which you'll put yourself into more problems in the sense that, you know,
I know, but sir, means like the data is positive, patient is going to relapse in next 3-6 months probably.
But that is, to be very honest, it is not approved. You know, you cannot monitor based on the CTC that the patient is responding or not. Right. It becomes very difficult also. So right now,
but maybe in the future trials, maybe
future is
around that.
I remember CTC is going for the last 10 years. The future is still to come. That's the only thing which I can answer. So my question is that EGFR mutation positive L858, what is the next step? Will you give post chemotherapy or you will give without giving any chemotherapy? Osimertinib.
So if the patient is actually fit for chemotherapy, I would give chemo and then only osimertinib. The patient is not fit, then maybe directly osimertinib.
Okay, so I think we have a lot of data regarding the role of adjuvant therapy. I will not go too much. There are we have studied so much about the adjuvant chemotherapy, practice very less in our practice, and we know that the stage B, 1B onwards, the data is very strong. And Adora has almost changed the way we look into the practice, but a lot of drawbacks. Financial toxicity is something issue. OS is still a thing which has not got come up at all. And Nikhil had presented a very nice slide, but something like which we cannot avoid, talking about is the DFS. You will hardly see this kind of DFS of hazard ratio 0.17, 0.20, and something which is very tempting for everyone to give at osimertinib. So I have one small question is that, Samir, you think this now Adora is now going to change the whole way? We know that we are prescribing. Only problem is that we have to find the patient, like, to give it, right? Any patient from your side whom you are giving adjuvant osimertinib?
No, sir, not yet.
Not yet.
I already told no patient got adjuvant chemotherapy in last 1 year. So definitely osimertinib is out of question. But definitely, sir, if I get a chance, I would offer, because it's actually I want to share one of my patient's experience. So he was my close relative. He underwent a surgery around 3 years back. He relapsed immediately within 1 year. He was EGFR positive at that time, but he relapsed in such a bad state that he could not receive even EGFR TKI. He died within 3 months. So such things happens. Means if the patient sometimes they relapse so bad, they may not get a chance to receive a good systemic therapy. So I think for Indian setting, I think DFS is a good primary endpoint, where in such a case where the high risk of relapse.
Yeah. So I think
for that patient, the first chance is the last chance, I think, for me. Yeah. So I would definitely offer them if there is such a good DFS benefit.
Yeah, there is one question which Dr. Sahu has also put up. Dr. Vikas, can you answer this? What if the patient is having PD-L1 90% EGFR mutation positive?
Truly, like there are immunotherapy which are approved, sir, but the result and all the trials, the details I don't know.
So basically, if a mutation positive PD-L1, standard practice is to follow the driver mutation, right? We will not give importance to PD-L1 when the driver mutation is so strongly positive. Osimertinib and immunotherapy, normally it's a very dangerous combination because there's an increased tendency to increase the rashes and other toxicities increases. So if a patient has got a EGFR mutation positive PD-L1 90%, we should go ahead with the osimertinib only. Right, Dr. Sahu? I think anything?
I think that is the data from IMpower 010 very clearly points to also one more thing, that the patients who had a ALK or a EGFR actually did not benefit much with the adjuvant
benefit from the
adjuvant atezo.
Even the IMpower 010.
Yeah, this one.
So I think we are very clear in our thoughts right now. This same thing. IMpower 010. I had a slide where I have not kept it over there, but yes, what Dr. Sahu said is very clear. ALK and EGFR is something which is important to think. So I think important thing is this is the one.
Can I ask a point to the panel? Yeah, this one. You have the slide with you.
Yes.
Go and the things, the EGFR is below the highlighted one and the ALK is below that. Yes. If you look at it, if there's a rearrangement, you don't much benefit.
They don't do too much benefit.
Yeah. And the PD-L1 status does make a difference.
Yeah. I think
sir, what is the cutoff of PD-L1? PD-L1 more than 10 or 1?
No. More than 1 they benefited, but if you want a real benefit, it's real beyond 50. So in a setting where
you can see here 50. Yeah. This is the pattern. You can see what Dr. Sahu is telling. 50 has got a very strong benefit. Yes. More than 1% is the one which is approved.
Yes, sir.
If you see
but the IMpower, more than 1% also hazard ratio is 0.6.
It is positive.
More than 50%.
Can I ask the panel one thing, Tejinder, on your behalf? With the 2 medical oncologists, when you are there in Mumbai, where do you place immunotherapy today in the neoadjuvant scenario? Point number 1, with the nivolumab data. And that's what I wanted to first ask. And then where does the panel feel all about the adjuvant immunotherapy today?
So my knowledge about, there are so many immunotherapy data coming up in the new adjuvant setting, and I feel it is very promising. The good thing about that thing is that the CR rate, if you see the nivolumab CR rate, the CR rate is in the tune of around 26 to 30%, which no other new adjuvant chemotherapy has shown. How much that is going to convert into the survival as a surrogate marker, we do not know. But the resectability pattern has not changed grossly, but the CR rate has improved a lot with the new adjuvant data, especially with the, I think the new adjuvant nivolumab data has shown a very good CR rate, complete response. So I think it is very promising, very promising.
It is even more. With Nivo EP, it is even more.
Yeah, because the checkmate 816, that's what you are talking of, Tejinder.
Yeah.
And then checkmate 816 is very clear that the CR rate, which is a surrogate marker survival, actually it does increase from 2-3% to around 24%.
Right.
And that's one. Yeah. And second thing is the surgical part has become better. The radical surgeries have become lesser, and it has actually, pneumonectomy has actually come down. And that I think does make a difference to me. And adjuvant immunotherapy, especially for the molecular marker negative group, if the money can be there, I think that will be a big thing. Why I'm pushing for neoadjuvant today, maybe the trial is not ripe yet, because you just need 3 cycles. And then if you achieve a CR, you are going to probably achieve a better, longer duration of survival. That's what my point is.
And this Nivo and EP data is very strong, but some 33, 40%, whatever I know. But Nivo plus EP, but it's very promising data. And I think we are heading towards this alchemist, I feel, is going back where they are looking into ALK. But somewhere down the line, ALK also needs to be given very much importance, because these are the patients, they perform better than the EGFR cases.
EGFR. So Samir, will you do immunotherapy neoadjuvant given a chance?
I am very tempted, but right now, like Sahu said. Yeah, Samir, you answer. Samir is from the big institute, so he should.
No, sir. Right now. At least I want the DFS data.
Come on, take it. So what do you have to say on the adjuvant Atizo data?
Adjuvant Atizo data, definitely, sir. If the PDL1 more than 50, as you mentioned, definitely yes. More than 1, I think, should be discussed with patient.
Okay.
But it should be EGFR negative.
Yeah, that's sure.
Yeah. If it is less than 10, less than 1, then definitely no.
No, I will, like what Sahu said is very right. In the present area, we should discuss about the neoadjuvant immunotherapy. We should discuss about the adjuvant IO. There is a strong data at IMpower 010 is a very good study. And I think we have, especially with the PDL1 more than 50%, we should think about giving the adjuvant. The only thing is that finding the patient is very difficult, Dr. Sahu. You are the only one who might get.
Hey, Vikas is there. Who has the right to?
Yes, sir. Bole, sir.
So, I think Vikas, your last thoughts on it, because then we can.
Because your final comment. Yeah, we're already getting late.
So I think the ADURA trial had changed many things. The survival is, I am positive that the survival difference will also come, sir. As far as immunotherapy is concerned, they have made a difference in metastatic setting. With adjuvant also, like promising data is coming, and neoadjuvant setting, there is a more CR rate and more in data is required, especially the DFS and OS. So in the whole medical oncology, the lung cancer management is improving from stage 1 to stage 4.
Right. So I have one small question, Dr. Sahu. Cost is a big constraint. EGFR mutation positive L858. Will you replace osimertinib with a first generation TKI?
I will be tempted to, because I have one data to say on the adjuvant gefitinib. Those patients who actually took beyond 18 months and those who did not do 18 months, there was a difference.
I had also given in my practice.
Yeah, I feel if the patient cannot afford osimertinib, I would be tempted. If, as Samir told, you might not get a second chance. So there is something working. I will take a signature. And that data of 18 months and below 18 months, that graph when they separated.
Have you given in your patient? Have you ever given in your patient?
Adjuvant, as I told you, it's very, very rare.
Yeah.
I have not given an adjuvant in last 1 year, so it's very, very difficult.
Yeah, I had given to one of my patients gefitinib when the osimertinib data was not there. That's a different thing. because patient was around 80 years. I had no other choice.
Okay.
So how the duration of gefitinib adjuvant?
2 years. At that time, I had given 2 years. If you see, there is a first generation TKI data is there, but the DFS is not so strong like osimertinib.
Right.
And look at this hazard, Samir. It is around 0.6. It is not a very. It is not a very insignificant hazards, and the duration
very
didn't
high.
matter.
Very high.
So afatinib may not be.
Same, not so great. Not so great. Around 0.67 ke aaspaas.
Which one?
Afatinib.
Yeah, I bet toxicity. You in the adjuvant, you would want something very, very less toxic. And there is data, at least from gefitinib, from 2 studies, the hazards around 0.6. And it is a cheaper drug. But otherwise, osimertinib is the standard of care that all of us accept now. Maybe I am still waiting for the OS data. Vikas is very sure it will be positive. I would look at the data because I feel that's the data that will interest me a lot.
Thank you, Dr. Sao. I think we are already running short of time. Thank you to all the panelists. Thank you.
Thank you, sir.
Thank you, all of you, for that lovely thing. And thank you, Gaurav, for always being a sport for a thing which you have limited answers. Thank you, Vinod, for joining us for the first time. And it was great. Just to cut things short and make it very clear on a scientific podium, all of us do feel that we need a biopsy before we want to operate a patient of lung cancer, or we want to give a radical CT-RT chemotherapy. I think that point we want to be pretty clear. Right, Vikas?
Yes, sir. Yes.
Practice? Yeah. So I thought that was something confusion that happened. I wanted to clear it off, that the panel did agree that biopsy was the way to go ahead before you want to go and operate someone. So without much of a delay,